हेलो। हेलो।
Hello.
Madam, YouTube link is live.
Yes, I just saw
Yes,
it. Maybe
even
in
I
two
saw. Yeah,
minutes we'll start. It's
yeah.
5:59.
Yes, yes.
Yeah.
We're about to start.
Can we start the meeting or we will wait for 2 minutes? Because I think only 11 participants are there. Kalyani, unmute.
Yeah, in 2 minutes I think we'll start.
Hmm.
Yes, good evening.
Good evening.
सुरू करायची आहे का?
Good evening, ma'am. Good evening, Sarita ma'am. Good evening,
Good
Good
Shalini.
evening. Good
Good
evening.
evening, everyone.
I think we will start or we'll wait for 1 or 2 minutes.
I think we'll start, ma'am.
Yeah, so it will finish within time.
Yeah.
Okay. Good evening. Good evening, everyone. I am Dr. Sarita Swami, President of Society of Anesthesiology, Pune. Welcome you all for today's webinar. I would like to mention special thanks to Dr. Balaji Asegaonkar sir, President SAMS, Dr. Anita Nete madam, President-elect SAMS, and Dr. Rajesh sir, Secretary SAMS, for providing us this wonderful platform for academic event. As we know, nowadays many anesthesiologists are taking lead in quality and safety of the patients. Therefore, we decided to have the interaction with experts in this field. For that, we have invited today Brigadier Dr. R.N. Verma sir from Lucknow. Welcome you, sir. Dr. Sheetal Dixit from Mangeshkar Hospital, Pune. Welcome you, ma'am.
Thank you, ma'am. Thank you.
Dr. Shilpa Acharya from Bharti Hospital, Pune. I will like to hand over the next proceedings to Dr. Shalini Sardesai, madam. She is Vice President of Society of Anesthesiology, Pune, ex-Dean of Navle Medical College, Pune, and she will be moderating the today's session. Over to you, Shalini, madam.
Thank you, Dr. Sarita, for kind introduction. Good evening, everyone, and welcome to this very interesting webinar on quality in anesthesia, which is organized by Society of Anesthesiologists Pune in collaboration with Society of Anesthesiologists Maharashtra State Chapter. We all know that the perioperative mortality is very high. It is right from 0.4% to 4%. And WHO is saying that the patient admitted in the hospital, almost 10% patient develop trauma, while 20% patient develop trauma because of surgical intervention, and almost 34% which are admitted in ICU develops trauma because of the management. So out of that, 50% mortality is preventable, particularly death after complications, that is failure to rescue. Regarding anesthesia specific mortality, the incidence, whatever mentioned, statistics is showing that it is very low, but the cause of it is unreporting. Many times, whatever the adverse events occurs perioperatively, the reporting and its exposure or mention in the literature or in the our statistic is very less. But the anesthetic conduct or anesthesia management has a great impact on perioperative or post-operative outcome of the patient. So as an anesthesiologist, our main goal is safe anesthesia practice. Safety of patient, safety of healthcare or OT attendants, safety of the society is prime important. And quality care is the main key to reduce the perioperative mortality and morbidity. Hence, essentially, our continuous commitment to improve our practice of anesthesia and to provide quality care are mandatory. Now, even the NMC, that is National Medical Council, and many other medical educational organizations all over the world implemented the new competency-based medical education curriculum for undergraduate as well as postgraduate students, so that they can apply their knowledge for improvement of their clinical skills right from the beginning. It is not only that, it strongly advocate, the curriculum strongly advocate, rather mandate continuous quality improvement for all physicians. So what is quality? Quality was defined by Institute of Medicine in 2001 as it is the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. Quality can assist under different domains of quality like effective, equitable, timely, efficient, safe, patient-centered, and so on. If we set different protocols, observe various checklists, and reassess our own skills with adequate knowledge, will definitely reduce the perioperative mortality and morbidity. Today, we are highly privileged to have an eminent speakers, quality lead at different hospitals are here to enlighten us on different aspects of quality in anesthesia. So without any delay, I would like to invite our first speaker, Dr. Brigadier Rishiraj Verma. Sir is Professor Anesthesia, at present Dean, Institute of Paramedical Sciences, Commander 2 Technical Training Wing, AMC Center and School, Lucknow. Sir has vast experience in medicine and has been in armed forces for last 32 years, working as anesthetist for last 25 years. He was faculty as professor for 4 years in FMC also. He is a certified instructor of BLS, ACLS, and ATLS. His special areas of interest are changes and challenges in postgraduate medical education, regional anesthesia, pain management, simulation, and artificial intelligence in anesthesia. Now, sir is going to talk on safety in perioperative patient. Welcome, sir. Please.
Good evening. Thank you, Dr. Sardesai. I have two disclaimers before I begin. The first, I am not really an expert in this field. I think all of us who are practicing anesthesia and have some degree of experience to become experts in safety. Second, I have had very little time for the preparation of this presentation. So there is a possibility that the slides may not connect well. The flow of thought may not be there. Also, I have no idea how much time this is likely to take because I never had the chance of doing a dry run. Notwithstanding that, yes, I have been a professor of anesthesia in AFMC for 6 years. Currently, I am the Dean of Institute of Paramedical Sciences at AMC Center in College, Lucknow. And although I'm not at the moment very actively involved in clinical medicine, but still an anesthesiologist can never be very far from the OT. So with that, I'll just start the presentation. There are about 5.2 million medical errors which occur in India every year. It's a huge figure. So much so that now medical errors are being thought of as a deadly epidemic. They are the third leading cause of death after road traffic accidents and ischemic heart disease. There have been numerous reports which have come. During COVID-19, there was gas leaks, there was no oxygen, and so many other cases where patients have, even paramedics have reported use of mobiles during surgery. So this is one of the study by an NGO which says that use of mobiles during the study increases the number of errors. And I do agree. It all starts with the Hippocratic Oath, which said primum non nocere, which means first do no harm. So as early as that, it was well recognized. In 1843, Dr. Oliver Wendell Holmes, advocated hand washing to prevent childbed fever. In 1879, this is very interesting, that during a seminar at the Academy of Medicine in Paris, a noted speaker stood at the podium and cast doubt on the spread of the disease through hands. However, an outraged member of the audience felt compelled to protest, and he shouted, "The thing that kills women is you doctors who carry deadly microbes from sick women to the healthy ones." And that man was Louis Pasteur. In 1910, Josephine Baker started a program to teach hygiene to childcare providers in New York. 30 physicians sent a petition to the mayor protesting that it is ruining the medical practice by keeping the babies well. So that is what it is. But when did this modern hue and cry start? So in the year 2000, there was a publication by the Institute of Medicine to err is human, building safer health system. After that, there has been a lot of widespread interest in medical errors. How hazardous is healthcare? Well, there is a graph here which has been prepared by, I think, maybe WHO, where on the x-axis you have the number of encounters for each fatality. And as you can see, the airlines, scheduled airlines, it goes up to even 1 million, whereas healthcare, in just about 100 encounters, the figures of life lost are almost 100,000. So what is the burden of this in the US? So at an average, 7 million experience disabling surgical complications, of which 1 million die every year. Approximately 2 million per year perioperative errors, with estimated annual healthcare cost of about 5.6 billion in the USA alone. WHO statistics say, as we have just seen, I think that was the WHO graph only, 1 in a million chance if you are doing air travel, whereas 1 in 300 if you are undergoing surgery. Errors of anesthesia medication are as high as 1 in 20. In a study in a hospital in the US, there were more than 3,300 perioperative errors from 2015 to 2018. And in a study that was being done on low and middle income countries, the rate of adverse perioperative events was about 8%, of which 83% were preventable and 30% resulted in death. However, When we compare to what anesthesia was even 40 years ago to what anesthesia is today, it is safer than it has ever been due to the advances in pharmacology, technology, and more stringent practice standards. We are, of course, always in the forefront. Anesthesiologists and anesthesiology is among the leading disciplines with regard to patient safety, and we have to be. My professors and teachers who have taught me while I was a student at FMC used to say that anesthesia is like flying an aircraft. You have to ensure 400% that all the components and all the parts of the aircraft are functioning normally and well. Because up in the air, the only way is down. Second challenge is safe surgery saves lives, which focuses on prevention of complication resulting from surgery. And anesthesiologists are involved in patients' surgery throughout the perioperative period, which is preoperative, intraoperative, and postoperative. Now, the perioperative period, as I have said, is an extremely intense environment with multidisciplinary professionals, diverse and complex, high-cost medical equipment, sophisticated technologies, a large array of supplies, instruments, and implants, which are difficult to manage. We have all seen this, that our stores are always chock full. Vulnerable patients, time pressures, which create extremely high tensions in the OT. Peri-op environment is also a very unique environment. All these variables that I had enumerated create an environment of massive complexity and unfortunately are a source of significant percentage of patient safety related adverse events. Some major problems in the OT include addressing incorrect surgical site, patient's procedure, retained surgical items, medication errors, hypothermia, burns, inadequate emergency responses, and improperly processing of surgical equipment. So let's take an insight into the errors in the perioperative continuum. I say it's a continuum because, to separate it out into preoperative, intraoperative, and post-operative would be incorrect. It is a continuum. So peri-op accidents include serious and irreversible injuries and therefore require very specific precautions. Except for the surgeon, all the other clinical and support perioperative staff do not interact with the patients until the surgery and therefore have a very limited role in the post-operative room or in the post-operative period. The other support personnel, which include the patient transporters, the sterile supply staff, janitors, ward boys, and others, also directly affect the surgical safety outcomes. And this is where the importance of teamwork, which I think we anesthesiologists manage very well, continuous quality control, smooth communication, and information sharing between medical professionals to ensure surgical patient safety needs to be imbibed as a culture rather than as a once-in-a-while seminar. So is the medication safety the only issue? So the 5 rights, that is right dose, right drug, right route, right time, and right patient of medications have already been stressed on repeatedly. Highly sophisticated medications is what we are using. And as I tell all my residents when they start anesthesia, we are a specialty which deals with the most dangerous drugs in the entire hospital. Secondly, whatever drugs we use, once introduced into the body, cannot be taken out, which is completely different to what the other physicians, pediatricians, etc. are giving. The oral medication can easily be vomited out and so on and so forth. But once given, an IV injection can never be removed. But there are additional issues which need precise coordination for smooth functioning of the OT. This includes nurses, the surgeons, anesthesiologists, the surgical support staff, instrument, cart, surgical equipment, supplies, surgical pathology, medical gases, OT configuration, preparation and cleaning, clinical images, surgical schedules which have to be adhered to, and patient data if available from electronic media record. So let's take an insight into human errors in the perioperative continuum. First and foremost, there is a lack of familiarity with and knowledge about the patient. As I had mentioned earlier, this leads to errors in patients identification, miscommunication about the procedure, omission of allergies or antibiotics which the patient may have. All these problems get magnified at times of patient transfer, whether from the OT to the PACU or from the PACU to the ward. In addition, there is an absolute need to maintain a sterile environment, which creates physical barriers, and these physical barriers often result in the OT being closed off from the rest of the hospital. And this isolation makes patient transfers and data sharing even more difficult. So exactly what is peri-op patient safety? As per the definition goes, the internet says it's an absence of preventable harm to a patient during any surgical procedure. And this is fundamental in delivering quality perioperative care. The basic premise is to minimize risks and optimize outcomes for patients undergoing procedures, which means basically improving patient safety means reducing patient harm and accidents. So as we used to teach the residents, safety stands for S, start safety culture early. All of us in teaching institutions have residents, and we need to imbibe into them a sense of safety. Also, sense the error, be vigilant. A is always be vigilant. Act to prevent it. F, forget nothing. It could be the patient's comorbid conditions. It could be anything. So often we have seen that patients who are on the OT, there's a tendency of the paramedical staff to switch off alarms without actually noticing what the alarm is about. So follow safety guidelines and take it easy only after the patient has crossed the PACU. Inquire into accidents. Target vitals and blood loss. Take appropriate remedial measures. And always remember, it is your responsibility. Nobody else is going to be there to say, okay, it was not his fault, it was my fault. And why is it that the perioperative patient safety is different from other patient safety? Because we are working in a very, very complex healthcare system where there is a high stress in the perioperative period. All the specialties, most of the specialties have equipment intensive equipment. And though it may not be a willful negligence, but often systemic flaws, inadequate communication, widespread process variations, and often patient ignorance can lead to these kind of accidents. Also, as Dr. Sardesai was mentioning, there is always a tendency to underreport adverse events due to fear of litigation. So there is a classification that I have found on the internet. It says there are basically two types of errors: latent errors, which are management, administration, and equipment; active errors, which are basically human errors. So they are errors of planning, errors of execution, which can be mistakes, knowledge-based or rule-based, and errors of execution, which could be slip-ups or lapses. Further, we'll just go very briefly over some definitions of medical errors. So a medical error is an unintentional deviation from safe practice. An adverse event is a bad outcome, which may be physical or psychological, to the patient after any healthcare intervention. Medical errors are major and enduring loss of function, basically a failure to complete a planned action as intended to, or the use of an incorrect plan of action to achieve a given goal. Medication errors we are all familiar with. Any preventable event that may cause to or lead to inappropriate medication use or patient harm while the medication is in control of the healthcare professional, patient or consumer. We have all faced what is called as a near miss, which is basically an error that has the potential to cause loss, injury, or illness. But it did not because of pure chance or because it was recognized early and it was intercepted. Again, adverse drug reactions, we faced it. That is basically a noxious or unintended response to a drug which occurs at the usual doses, which may be used for prophylaxis, diagnosis, or treatment. So, in a study, The 10 highest priorities, perioperative safety issues which were there were wrong site, procedure patient, wrong procedure, wrong patient surgery, failures in instrument reprocessing, retained surgical items, surgical fires, pressure injuries, specimen management errors, perioperative hypothermia, burns from energy devices, medication errors, difficult in intubation and airway emergencies. In another study which I checked up on the internet, I found a statistics of errors which said equipment errors were the leading cause, and almost 29% were equipment errors. This was very closely followed by, and surprisingly, communication errors, where there was a cartoon which I wanted to add, but somehow I missed out. The communication which is passed down from one person to the other becomes a Chinese whisper at the end. Then followed by medication errors, which are 9.7, wrong site surgery at 5.6, and surgical site infections, which are about 4.3%. The common anesthesia mishaps include judgment errors, medication errors, inadequate resuscitation, ventilation, reversal, crisis management, monitoring, post-operative management, technical mishaps, aspiration, wrong choice of patients or wrong choice of anesthesia in patients, hypoxic mixtures, and so on and so forth. So, is it always a human error? Well, we all know, and somebody has very rightly said, the search for someone to blame is always successful. If you want to fix blame, yes, you can always find some scapegoat. And we do that very often. And traditionally, errors have always been attributed to incompetence of individuals, because all of us are headhunting. We want to fix blame. The emphasis, therefore, was laid on individual training, which is a personal approach of error prevention. However, this approach is flawed because errors are not always due to incompetence. And research has shown that it is multifactorial, and even very, very competent individuals can commit errors in the, as I mentioned, a very high stress and a very intense environment of the OT. So there is a figure that is displayed here, which shows the complex interaction of job factors, attitude, subjective norm, behavioral interaction, perceived behavior control, so on and so forth. And all these go on to create what is known as the human factor. So is it really a human factor or a system error? So again, system errors are lapses in safety attributed to conditions in the work environment, which cannot be altered. And most frequent of these are related to job and systemic factors, such as safety management system. Job factors like excessive workload and complexity of the job, which increase physical and cognitive burdens on healthcare professionals, thereby decreasing their ability to engage in safety management activities. Safety management systems include safety training, participation in safety policy, management supervision, communication, and feedback. And safety management activities in the OT should be examined considering both individual and organizational factors result from their interaction. So it is not just a human error, it could very well have a systemic flaw also. So what is a systemic approach? This is where the organization steps in. And the systems approach has been successful across a broad range of industries, whether it is the airline or the space agencies and so on and so forth. This approach is based not on blame, but rather on recognizing that clinicians function within a system that predisposes to errors that create harm. The systems approach focuses on new practices that make the entire system error resistant. Rather than trying to train the individual, let's make it so that the system itself is error resistant. And one of those is an example of non-interchangeable filling ports, which eliminate the possibility of filling the vaporizer with the wrong volatile agent. I think we have all seen vaporizers which are color coded and shape coded in our practice. This is a better preventive strategy than personal approach that focuses on training the concerned person to recheck the type of agent before filling. So was it useful? Or use of IT, has it been useful? So there was a program which was launched, which was called the Computerized Physician Order Entry. This was in the West. Exact country, I'm not sure, but probably it was in the UK. It was a software created to support possible direct online order entry of medication by physician. And as it was, the physician creates a clinical order It is sent to the pharmacy, which goes for a pharmacist review. Thereafter, the drug order is filled and a nurse administers the drug guided by online medication administration software. So the CPOE paradigm, however, does it fit us? Anesthesiologist in the OT? No. Why? Because here we do not have so many steps involved. All the three functions such as ordering, filling and administration are performed simultaneously by the anesthesiologist. Furthermore, the CPOE software does not support the other 15 things that I had talked about. Planning and preparation of the OT in case of medication inventories, after case documentation, inventory replenishment. So certain international patient safety goals have been formulated, and these goals, I will just quickly go over them. The goal 1 was to improve accuracy of patient identification. It says use at least 2 patient identifiers. Prior to start of any invasive procedure, conduct a final verification, such as a timeout, what we are using in the surgical safety checklist. Improve effectiveness of communication among caregivers, which is the second biggest cause of errors, measuring about 24%. Goal 3 is to improve the safety of using medications. We'll come to medication errors later. Goal 7, reduce the risk of healthcare associated infections. Initiate the SIP protocol. Again, we have a slide on that later. Goal 8 is to accurately and completely reconcile medications across the continuum of care. We should never forget that if the patient has comorbid conditions, the medications will continue intraoperatively and postoperatively also, most of the times. And lastly, reduce the risk of surgical fires. Oh, sorry, there's another one. So encourage patients' active involvement in their own care as patient safety. Define and communicate the means for patients and their families to report concerns about safety and encourage them to do so. So any patient's relatives who is sitting along in the with the patient can tell that yes, this patient has had a biscuit to eat, and therefore an error can be prevented, especially if it is a pediatric age group. I've seen a movie on this where they have talked about a murder for a child who had a biscuit pre-operative. Now, is this only applicable to low and middle income group of countries? What about the developed nations? So Netherlands is a high income, high performing group country, and it still has significant morbidity and mortality post surgery. So they started a national program based on evidence-based perioperative safety guidelines. And this was based on the SURPASS checklist, which I will come to again later, and spanned the entire journey of the patient in the perioperative period. Then there was an improved study, which is again available on the net. If anybody is interested, you can check on this. And what it basically showed was that just providing guidelines is not enough. The organizations require resources and expertise to create a social climate. As I said, it has to be a culture for change, to collect data, monitor outcomes, and support improvement work. The local context was taken into consideration and observation with immediate feedback was performed. So the IMPROVE study. IMPROVE stands for something which I cannot pronounce because it's in German. It describes a large perioperative quality improvement project while reporting both compliance with improvement activities and patient outcomes. Challenges identified in implementation included importance of effective training and practice change, selection of trial design, and relevant quality measures, and how the context of quality improvement initiatives may influence outcomes. Quality improvement programs of this nature remain high priority because of their positive influence in improving clinical practice. So this had two components. The first was to test the effectiveness of a multifaceted implementation program. And second was to assess the impact of these safety guidelines on the outcome. The intervention and implementation program was introduced across 9 hospitals in a stepped wedge design with 3-month initial data collection and 4-month implementation period. The implementation and intervention consisted of activities well recognized in the improvement world, such as presentation of the problem, use of experts, opinion leaders to create vision for action, and importantly, engaging emotion with patient stories. So we all are familiar with the WHO safety checklist, but I'll just tell you briefly about the SURPASS study. So WHO safety checklist has now been time and tested, and it has been proven to have benefits across the immediate operative period. This has been extended to what is known as the SURPASS study, or the Surgical Patient Safety System, which has been extended to improve the entire perioperative continuum. And as it would be expected, Anesthesia Patient Safety Foundation has come up as an organization committed to patient safety. It has devised a standard plan to prevent errors in the perioperative period using technology solutions, standardization, pharmacy solutions, and improvement in institution culture. So what are the proposed solutions? Use of IT. We have seen what was the previous IT which was used by physicians. Here the suggestion is to use barcode assisted labeling and administration. The coded label is scanned before administration of a drug. The computerized system displays all allergy alerts which are stored in patient records, or reminders to dilute if a vasoactive agent is being used, or a cross check for other drug interactions. This particular proposed solution is effective, but it involves additional cost, requires anesthesia information and management systems. The second one is proposed solution of standardization. A standardized arrangement of the drug tray, standardized storage areas, standardized drug concentrations, especially vasoactive agents, standardized drug color coding systems, which we used to use when we were residents, labeling protocols, and non-interchangeable characters for vials and syringes. This is another project which is likely to come up, where you can use only particular syringes for one group of drugs. If it's for induction agents, they will have probably some kind of a shape index system. Okay, and what does this help in? Standardization helps to pick the right drug quickly in an emergency, because it is easier to see color than to read the label. And therefore, it decreases the time wasted for searching, prevents the wrong dosage, avoids error due to misreading of labels. And often, if you remember, the color codes that we were using, they were all fluorescent and therefore used to stand out. Another proposed item is to use Tallman lettering such as dopamine and dobutamine, which I have shown. If you capitalize the DOP and the DOBUT, it stands out. Label material should allow writing with a ball pen without a smudge, and along with the color-coded and boldly labeled extension lines to prevent wrong route administration. Same thing can be extended to pharmacy, where maybe it will cost more, but we could have barcoded pre-filled syringes, pre-diluted infusions, avoidance of look-alike containers, which is a very commonplace. And yes, in Midoset and Midazolam, I still remember there was a confusion in our times. Involves additional costs and may not be possible in all centers. Surgical site infections, there's a huge burden. Any patient who gets an SSI is twice as likely to die, 5 to 6 times more likely to require readmission, likely to stay in the hospital twice as long, and additional cost from the complications could be as much as 30,000 to 50,000 per major surgery. However, as per this thing, 40 to 60% of the SSIs are preventable. Overuse, underuse, improper timing, and misuse of antibiotics occurs in 25 to 50% of the operations. So there are quality measurements of surgical infection prevention, which is what is SIP. As I said, I have a slide on this. The quality measure number 1, administration of antibiotics within 60 minutes of the surgical incision. Quality measure number 2, use of appropriate antibiotics afterwards, and discontinuation of antibiotics within 24 hours after the end of surgery, 48 hours after cardiac. Additional quality measures such as control of glucose levels during surgery, avoidance of hypothermia, use of supplemental oxygen during surgery and the post-operative period, and as it has been advocated in practically every surgery, clipping rather than shaving at the surgical site. There's another one called SCIP, Global Initiatives on Patient Safety. It significantly reduced surgical complications by reliably implementing 4 changes in care recommended by the Surgical Care Improvement Project. So that is prevention of surgical site infection, beta blockers for patients on beta blockers prior to admission, prevention of venous thromboembolism, and prevention of ventilator-associated pneumonia. Additionally, consider teamwork and organization. So I have finished. I hope this presentation had some continuum. I'm not too sure, but that's how it is. And as I said, I have not been able to time it. So I think I've exceeded my time a little. Any questions, please?
Yes. Is there any question from the audience? Kalyani, is there any question in the chat box?
No, ma'am, there are no questions.
Okay. Thank you, sir. Thank you for your wonderful talk on safety in anesthesia in perioperative patients. In spite of having emergency at home and short of time, you have given wonderful talk. You have nicely explained about this, what is meant by safety, what are the possible errors, and what should be the system approach for it, and what are the proposed solutions to be recommended to the pharma company. So it was overall wonderful lecture, sir. Thank you, sir. Thank you very much.
Thank you so much, ma'am. And if you will permit, I'll leave the meeting.
Yes, sir. Sir, thank you and best wishes, sir,
Thank you.
for recovery. Now, I invite our second speaker, Dr. Sheetal Dikshit. Madam is clinical lead quality and accreditation and consultant anesthesiologist at Dinanath Mangeshkar Hospital, Pune. She has done executive postgraduate diploma in healthcare administration from Tata Institute of Health Sciences, Mumbai. She is a course director for American Heart Association accredited advanced cardiac life support, co-director Royal College of Surgeons accredited care of critically ill surgical patients. She is also a faculty of American College of Surgeons approved advanced trauma life support course, that is ATLS. Now she is going to talk on quality improvement and the anesthesiologist. Welcome, ma'am.
Hi, thank you so much, Shalini ma'am. Thank you so much for that lovely introduction for me. I'm just going to, am I to share screen or would you be doing that, Kalyani?
No, ma'am. Ma'am, you'll have to share it from your end.
Can you see it?
Yeah.
Yeah.
Yes, ma'am.
All right. I'm just going to put that in slideshow mode. Yeah. All right. So that
Yeah.
after that very lucid talk from Dr. Verma regards obviously perioperative incidents and where all we can sort of go wrong, and there can be misses, there can be major errors. Since most of us, a lot of us as anesthesiologists are going, getting involved in the quality journey. Some of us because we like it, and some of us because we have to. But believe me when I say this, that there is no other, specialist who should be actually spearheading quality improvement in a healthcare organization except an anesthesiologist. And I'm going to kind of put in a little bit of my experience here as well to prove that point. So, quality improvement in healthcare is a new field, definitely. The only thing is, in most setups, what has happened is we're trying to sort of adopt from the manufacturing and the industry sort of principles. We can definitely take from that, we can sort of take that as, just as a roadmap, maybe. But it is time for us to develop our own quality improvement initiatives. So on the basis of that, I'm going to start my little talk here. Just like Shalini ma'am said, so many years ago, there was, there have been deaths because of anesthesia. This is a paper that was way back in 1948, 52, right? This is about 75 years ago. And at that time, you had close to 2 deaths or 3 deaths reported per 10,000 patients. Now you have maybe 1 death reported per 2 lakh to 3 lakh patients. So believe me, as a specialty, we have improved leaps and bounds. Yes, so it wouldn't be really wrong to say that we, as collectively as anesthesiologists, and the science of anesthesiology has improved leaps and bounds with respect to patient safety, and that is the reason that the baton of patient safety must completely be in the hands of the anesthesiologist. See, it's simple. A patient dies because of either A problem, a B problem, or a C problem. There is no other way to die. And we know this from the back of our hands, maybe even back of our feet. I think most of the anesthetists would agree, right? So, I'm going to reiterate Shalini ma'am's definition for us, defining quality. Absolutely. It was defined in 2001 by the Institute of Medicine. And it was titled, of course, Crossing the Quality Chasm. I would say that the degree of anesthesia services for individuals and populations increases, the quality means to increase the likelihood of desirable anesthesia outcomes, which are obviously consistent with our professional knowledge. So obviously, we want that degree of anesthesia service to be provided, which is obviously going to give us a likely desired outcome, right? Okay. Just as ma'am said, yes, anesthesia has to be safe, it has to be effective, it has to be patient-centered, it has to be timely, efficient, and equitable. Now, I'm going to look at how we do that. We are already doing this, okay? Looking at the safety, for safety, we're looking at the WHO checklist, right? We have an airway check. Every time we check our airway trolley, irrespective of whether I have done it or whether the technician has done it, we will do an airway check. We will do a machine check every day. We will have a monitoring checklist where we as a specialty monitor every 5 minutes, right? Tell me which other specialty does that, right? Now, let's see if we are effective. Okay. Now we look at pain in terms of a VAS score, isn't it? It's a verbal, it's a VAS score for pain, right? It's a visual analog scale, right? Now, pain is something for which the patient is coming to the hospital, right? So on VAS, we can do studies like PREMS and PROMS. I will come to that later on. Okay. Next, are we being effective? Okay. So let's take the point about evidence-based. Now, you, all of us, or most of us, do use ultrasound for cannulating central lines. So we have sort of gone up and said, okay, this is a safety issue. Maybe the possibility that I may cannulate a carotid is very, very high. Thereby, we have moved to cannulating lines with using of ultrasound, isn't it? How about patient-centered, right? Where for patient-centric, for patient centricity, we're looking at, well, we're using epidurals, we used to use epidurals for pain relief, right? But now if epidurals is going to hamper my patient mobility, I'm using blocks. I may use PCAs, right? And that is going to definitely impact your average length of stay, right? If my patient is pain relieved and walking around, patient's length of stay is definitely going to increase. Am I respecting the patient's choices? Yes, definitely. We've been taught that. If patient says no for a spinal, we are not giving it, right? How about labor epidurals and increasing the patient experience, okay? And giving her that wow moment. We are giving her pain relief in the worst painful period of her time to have, to experience motherhood pain-free, right? If we have a Jehovah's Witness, my God, can you imagine? We also take that, we're taking all that burden, right? We're taking all that risk, but we're totally patient-centric. Then timely, we're giving rescue analgesia, we're providing acute pain services. How about PAC clinics, okay? Timely PAC clinics help in pre-optimization of our patients, can avoid rescheduling. Again, you're improving on the quality of healthcare. If you're avoiding rescheduling, definitely you're giving good outcomes there. Okay, you're even saving patients' money. You're saving the organization's money. By making sure that your operation theater is utilized well. Okay, how about avoiding waste? But efficiency is avoiding waste, right? So if you're going to avoid if you're going to do effective PACs, you're going to optimize patients properly, you're not going to cancel them on a day of surgeries, you are avoiding delays, okay? And of course, providing equal quality health for quality care for all. Yes? All right. So well, yeah. Now, it is, people say that, well, to improve, you need to measure what you are doing. There are two schools of thought. The one on my left, he needs no introduction. Obviously, he is Albert Einstein. Everybody knows him. He had a saying that not everything that counts can be counted. Okay? And not everything that can be counted counts. I'll give you an example. So just yesterday, a patient came up. I got a little card from a patient saying, "Thank you for talking to me and relieving my pain. You mean the world to me." Now, I think this counts because I think it's a lovely note, but I don't think it can be counted in a metric. Okay, I cannot sit and count how many of my patients gave me thank you cards. Okay, so definitely this feedback counts, but not everything can be counted. On the flip side, Deming, who is, we call him the quality guru, he is actually somebody who actually made that PDSA or the PDCA, plan, do, check, act cycle that we use for our audits. Okay, he says, well, if you can't improve unless you measure. So quality, if you want to say quality, it has to begin with a measurement. Okay. Now, when we come to quality improvement tools, everybody's scratching their head. Exactly what do you want? Okay. There are quality tools like check sheets, there are fishbone diagrams, there are histograms, Pareto charts. Okay. There can be something like a DMAC or a Lean Six Sigma or cause effect diagram. See, like I said, we have taken from the industry the concept of the quality improvement. We have taken from the industry. We can sort of just use that as a roadmap. It is not possible for us to sort of completely ape the industry. Please remember that. However, we can definitely sort of take that or use that roadmap. Why is that going to happen? I'm just going to go ahead and look at a few quality tools that I have picked up to sort of show how we can use these effectively in our anesthesia practice. Yeah. What's a quality tool? It can be anything. It can be a chart, it can be a device, it can be a software, it can be a strategy, technique, anything that improves quality efforts, right? You Google it, you will get at least 10,000 of them, and all of them are going to look like this, okay? So there's no need to sort of bog yourself down with what it is and how I'm going to, how I will apply this, not required at all, okay? So a role in quality improvement, one, okay, standard and compliance. And standards and compliance, everybody knows these days. We have an audit that happens, maybe hospitals who are NABH approved know what a standard and an objective element is. Okay, I'm going to touch a little bit on the quality tools that we just looked at. I'm also going to talk a little bit about the audits and clinical pathways that we presently being following a little bit. Quality improvement, I think we as perioperative physicians can go a long way in improving quality, and obviously, and how do we improve quality? By obviously improving patient outcomes, isn't it? And we also have, and I've got this at the bottom, but I think it should be at the top. We are pioneers, and in fact, we are real supporters of simulation training, much, and we've been on the forefront of this. So that's how I propose that quality improvement can be a very major aspect in anesthesiology practice. Okay, so standards and compliance, very simple. We have an NABH guidebook. There are certain standards and there are objective elements. Like, for example, an informed consent has to be taken. Okay, if you've not taken informed consent, the NABH auditor is going to come and say, okay, COP7E, you have a non-compliance, please correct that. You're going to send him or her 10 informed consents that are signed, and okay, your objective element has been met, and okay, your non-compliance is now a compliance, and then you are good. Okay, so I think we need to go beyond this. We definitely need to go beyond this. We talked about how safety, effectivity, patient-centeredness, we are already doing so many things. Why can't we go beyond this? Okay, so from the very first aspect, let's say we look at a fishbone diagram. A fishbone diagram is typically a cause analysis tool. Okay, it's also considered one of the basic, very basic quality tools. It looks like a fish. Okay, the head now here, okay, has, if you see the head here, the patient unfortunately has not been prescribed a correct anticoagulant. Okay, now that is the effect. And the causes, they say, are the bones of the fish. Okay, so in any aspect, be it life or anesthesia, these are going to be your problems. Was it a communication problem? Was it a policy problem? Was it a monitoring problem? Was it that the person was not credentialed or educated enough? Was it an environmental problem, or was it a documentation problem? Okay, now have your big basics up on as those bones, and make smaller things. Okay, now to make those smaller little aspects, ask yourself, okay, there's probably the prescriber was not educated enough. Okay, why was he not educated enough? Because probably that is not in his or her domain. Why is it not in her domain? Because she does not know anticoagulants. If she does not know anticoagulants, what gives her the authority to prescribe it? So here, again, we're going to go to policy and say, okay, there will be a policy that anticoagulants will not be prescribed by people who are not educated. Okay, let's say an RMO or somebody like that, right? So now you have your problem, you also have your solution. You need to make a policy on it. Simple, right? So that's about using a fishbone diagram. Just like Sir said, Sir talked about a medication error. Okay, a medication error happened. What medication error happened? A muscle relaxant was given instead of a sedative. Why was a muscle relaxant given instead of a sedative? Because they looked same. Why did they look same? Because they are look-alike medications. Why were they look same and they were stored together? Why were they stored together? Okay, so you have your problem, you have your solution, store them separately. It's as simple as that. Okay. That's how the 5 whys work with fishbone diagram. Yes, that's how it works. And definitely try it out in life as well by repeating why 5 times. The nature of the problem as well as the solution becomes clear, right? Try it out. Okay. Let's say there was a delay in OT50. Why? Anesthesia was not induced on time. Why was it not induced on time? Because the machine check failed. Why? Because there was a leak. There was a machine problem. There's a calibration problem. We don't know. Why did that happen? The technician was not aware of the leak test. Why did this happen? Because machines are new. The training of technician is still going on, and my technician and me were not trained. This is a real example. Believe me, this happened with me. So I just sort of put it up on paper. It's as simple as this. Before the 5th why, I have an answer. So I know exactly what to target. Yes. Next, let's come to a flow chart. Very simple. Flow chart is a picture of separate steps of a process in a sequential order, similar to this. Okay, there's a start, there's a sequence, and there's an end. Okay, now let's say my husband's into manufacturing, so I got a little process flow chart from him. There is raw material. Okay, there is a planning on production that happens. Okay, there's a manufacturing process. The content that is manufactured in his case, some pharmacy, let's say packaging material, it goes under QC, quality control. Okay, there's an assembly, there's a delivery, and of course things are in place. But it starts off with something, as you can see very nicely, it starts off with something called a design. Okay, a design is very important. Just like you must have heard, there are lots of books, live by design, not by default, and all. So everything has to have a design, right? So when you identify a process flow, now it's possible to benchmark it. Means like, for example, okay, I need 50, 60 bottles coming out every 10 minutes or 1 minute. Okay, that's my performance measure. Now, if production is going slower than that, I need to know where to act. Who are the responsible parties? Is the electricity not working? Is my man not working? Is my equipment malfunctioning? Okay, all that. So I'm going to collect data. I'm going to set my goals. This has to happen. I'm going to get into the corrective action as to where exactly the issue was. And then, of course, I'm going to implement change. Let's look at our process flow. Okay, pre-anesthesia, anesthesia, and post-anesthesia. Now, we have a pre-anesthesia visit or a PAC visit. Our main aspect here is risk assessment and preparation. Okay. Now, if this is going to happen 2 weeks before, I can strategize for this as to how I need to give anesthesia, what I should do in the post anesthesia phase, isn't it? Right. So, well, if let's say I have a patient on who has severe cardiac disease and he has to sort of undergo a TKR, okay, then it is important that, well, prehabilitation exercises happen, a good amount of cardiac fitness happens, his or her medications are properly optimized. So the buzzword here is, if I'm pre-optimizing my patient correctly, I am going to get him to have anesthesia that's going to be safer. I'm going to get him to post anesthesia wherein this is going to be safer, and he's going to go home as planned. So we do have a process flow. And of course, our major target here, risk assessment. What is the risk? Okay. And in this situation, this is a good time to meet your patient relatives, talk to him or her so he knows what the anesthetic is all about, he or she knows what to expect, and he knows a little bit about the outcome. So definitely, can a process flow help? Most definitely. Next, brainstorming. Okay, I love this. This is, let's say you have to create a website for your department. So brainstorming somewhere is a place where you're going to generate a lot of creative ideas. So you're going to actually ask your residents, your technicians, your nurses, everybody. Okay, let's see what is it that we can do. Okay, allow a minute of silence for everybody to think about that question. Invite people to call on their ideas, maybe put them on post-its, and everybody puts their post-its together. The issue is, just like Verma sir said, we work in a complex environment. Okay, we have complex environment. We have we working with people with different credentials. Okay, there are highly educated and extremely the intelligent lot. Whereas at the same time, we also have people who are not that credentialed. However, most important for the functioning of the operation theater and the anesthesia and the operation theaters, and obviously the anesthesia workstations and the anesthesia part as well. So everybody has to work just like a well-oiled machine. And if you want to really involve everybody in this, you're going to actually help your team grow. So brainstorm is something that we very regularly do, and definitely it generates good ideas, right? So idea creation or ideation. Next quality tool I quite like is called the Pareto principle. And think about this. The principle of factor sparsity, it illustrates that 80% of our effects arise from only 20% of causes. Okay? That and it was actually an Italian economist who said things like, well, 80% of the wealth is only with 20% of the population. And so true. Okay. So when you ask, okay, what's the problem? I've had a medication error. So what kind of medication error have we had? If you have a list of medication errors, let us say, and this has happened again. So maximum medication errors, did you have a medication error with a muscle relaxant? Or was it with a benzodiazepine? Was it with an induction agent? Was it with an opioid? You come up with, okay, let's say you come up with, no, we've had maximum errors you see are with muscle relaxants. Okay, so that is 20% of your problems. Now work on that. Once you have a proper policy, a proper storage, a proper like sir said, standardization for this, 80% of your work is done. Okay, so prioritize that, fix that. Okay, so just on a lighter note, my favorite example is 20% of the people in your life are likely to create 80% of your stress, aggravation, wasted time, and lack of productivity. I hope most of you agree with this. So it's like that. Work on that 20% for 80% output. That's what the Pareto talks about. Yes? All right. Now we come into that zone wherein we say audit. Okay, welcome to the audit. We tick all the right boxes. Okay. So when we say audit, I remember as an assessor, when I go to see audits, it's amazing what all is audited. It's like, oh, okay, We audited 10 people. How many? What's your? How many people were there? About 10 people. What have you audited? Delay. Operation theater delay times. Why was it delayed? Oh, because the patient didn't come, and that's the end of the audit. So audits are they have to be very focused exercises. Okay, it should not be, oh, brace yourself, the audit is coming, just like the winter's coming. No, let's do audit something if you believe that there is a problem and you want to find a solution. Okay, otherwise it's going to be a waste of time, and unfortunately it's going to take up a lot of your effort. Okay, and really not going to benefit you or your team. Okay, so I have a small little audit that we've done here. I'd like to present that in case, of course, we have time. We know what the definition of an audit is. It's a quality improvement process that seeks to improve patient care, and outcomes, a systematic review of care against explicit criteria and the implementation of change. Again, I think this is a little lengthy thingy, but let's see how, let's see how to look at a clinical audit. Okay, it's a tool to find out what you are doing, compare it to expected conditions, like compare it to a standard, what you should be ideally doing. Okay, learning from it and changing if necessary. Okay, once you finish that audit, you want to reevaluate and see if you can go further. Definitely identify, it promotes good practice. You have opportunities for training and education, helps better use of resources, provides assurance, develops guidelines, definitely enhances patient safety. I'm not going into the great details of the types of audits and everything for lack of time. It definitely differs from research in a way that, a clinical audit is just determining whether you're doing the right thing. And who's deciding the right thing? You are. Okay, you are deciding a standard, and you're just seeing in your audit whether you're sticking to it. Very simply. Okay, I have a cuff pressure audit, say once in 3 or 4 months. And one technician goes to all the ODs and says, okay, what is the cuff pressure? What should it be like? Ideally 25 to 30 mm of Hg. Okay. What is my compliance rate of cuff pressures? It's as simple as that. If it's not, then okay, you need to sort of get into the groove and keep your cuff pressures, ET cuff pressures between 25 to 30, right? Okay. Now, how long does it take? Please remember, this is very important. Do not carry on or drag on your audits for months and years. No. Data collection, analysis, and action plans can be carried out in an hour or two. Okay, you can do that. You can have a cross-sectional audit. One day, okay, you're doing say 10, 20 cases, all of them cuff pressure audit. That's cuff pressure audit day. Okay, depends on the design of your audit. Please design your audits to produce some amount of meaningful data, right? And implementation of the required changes. Okay, again, try to come up with 1 or 2 standards. Don't say I'm going to achieve 20 standards. It's going to be difficult to keep a track and keep data and keep following it up. So an audit cycle is very simple. Step 1, identify a problem. Okay, a real one. Okay, define your criteria and standards, collect your data, compare that with your standards. Okay, implement that change. Okay, and then after you've implemented that change, maybe is there a necessity to re-audit? Yes. So here we sort of I'm just going to present a small thing regarding the compliance of use of a clinical pathway. We call it the DMS protocol for all fracture hip patients. Okay, we did this in about April of 2022. And I thought it was interesting, and we could also have sort of discuss this if time permits again. My problem was that my fracture neck femur patients, all old, and look at the average age, 77 to 85. Nowadays, we're operating on 90, 95-year-olds as well, isn't it? Right? So the problem was its management to address pain, delays of these because the referrals were not being done, physician reference was taking time, 2D echoes and cardiac fitness was taking time, and thereby patients were going home late. So my issue was addressing pain, addressing delays, and what we can do to discharge them early. Okay, so we did a total of that's the data for you. Okay. As you can see, average comorbidities at least 2 or 3. We had ortho anesthesia meet conducted. Was it practical to undertake the audit? Everybody said yes, a protocol. So our meeting was, let's develop a protocol. Will that help? Most of the people said yes. Can you get the information? Now, this is also important, where you're getting your information from and what is the information you want. Yes, we do have a very good medical records department, and we told exactly what we need, because ICD codes really help. You gave her the ICD code for the fracture neck femur, and she gave you data for these 50 patients. Then is the problem amenable to change? Okay, can we change something? Yes, we can use a clinical care pathway to change that. Is this topic a priority for the department? Definitely, yes. Because if we're going to keep fracture neck femurs for a very long time, other problems are going to set in. They're going to land up with hospital-acquired infections, later on go to VAPs. You don't want that to happen. Okay, do you have good standards and guidelines available? Of course. AOS guidelines are there, Journal of Geriatric Medicine. There's a huge number, data in anesthesia journals as well, ortho journals as well. Journal of Gerontology has a lot of good information as well. And who needs to be involved? That's important here. The ortho department, the anesthesia department for sure needs to be involved. Okay. What was our pathway that we had decided upon? On arrival, all patients who fracture neck femurs, as fracture hits, are going to get a block. That's a block on arrival. Patients must be posted within 48 hours of arrival. Focus for immediate 2D echo. We decided, well, departmental 2D echoes will happen only if there are nuanced ECG changes and maybe ADHF or something like that, or if the patient is really bad cardiovascularly. An early physician consult, and next, of course, POD1, weight bearing in physiotherapy and as per clinical conditions. Of course, this was a lot for us to take, so we decided to audit point number 1 and 2. So, choose your battles is what I can say at this point. Standards need to be smart. Okay, we've chosen because 1 and 2 because yes, this is something that we can do. Okay, this is our domain on an on-arrival block, and patient to be posted within 48 hours. So my standards, do they sound specific? Well, yes. Is it measurable? Can I get data as to how many patients did receive on-arrival blocks? Yes, I can. Can I get data as to see how many patients were posted within 48 hours? Yes, I can. We have to, the audit team needs to agree with them. Yes, we did get agreement from all the anesthetists as well as a lot of surgeons, all the surgeons who were there at the meeting. Are they relevant? Absolutely relevant to the case scenario. Absolutely. And theoretically sound, are they based on evidence? Yes, they are based on best practice evidence. Okay. So now I have my standards. 100% of my fracture hips must receive a BOA. Yes. And 100% of my fracture hips must be operated within 48 hours of arrival to the hospital. Okay. So obviously, retrospective data collection, we included only fracture hips, the ones that ortho said, okay, only neck femurs and subtrox maybe. Some of them they had, which did not fall in that category, were not considered. The source of data was MRD, okay, and we tabulated that data. The case notes, we had to, of course, cover the case notes to see whether the patient did receive block on arrival. And of course, we checked operation date from date of admission to date of surgery. Easy to find out how we were kind of. So this was quantitative data. We looked at it, and that's how we tabulated it in Excel. And this was what we got. For my first standard, my compliance was in that month about 44%. Yes. For being operated within the 48 hours, 90% of my patients did get operated within 48 hours. Okay, so block on arrival, we looked at why this percentage was so less. So yes, blocks were being given, but unfortunately not being documented. Sometimes the ER physicians gave blocks and not us. They recorded in the separate sheets. So yes, documentation errors did happen. Sometimes we were busy, yes, right? And in the posting of patients, we are pretty happy with our 90% compliance, right? Compliance is fairly fair. Rare issues like in non-availability of the OT, physician fitness, waiting for physician fitness. So that was again, discussed as to how much of physician fitness is really required, right? Okay. So then, of course, we decided that the next audit which should include a focus, an early physician reference, a physiotherapy, and early discharge. And this is, of course, we still are in the process of doing that. We've really not gotten into this thing, but regarding focus, literally 1st May, we have actually we go to get together and think about this as to how we can improve on this data. So what we've done is pretty much a PDCA. We planned to do something, we did it, we checked whether we are okay, and we've acted. Okay. And if you can see, this little step here is the standard. So now we decided to do 1 or 2, standards. Once you do that, then you can kind of go to, like I said, points number 2, 3, and 4 that are there. So build on your audit. Don't try to do everything at the same time. Otherwise, you're just going to fall backwards. Okay. So it's always a stepwise approach and a stepwise climbing up, right? So we analyzed ourselves. We said, okay, has your audit data actually achieved your standards? Well, quantitatively, yes. We did have most of our patients being operated within 48 hours, but definitely our block on arrival needs to improve. Okay. Can we expedite physician references within 24 hours? That we're still working on that. Departmental 2D echoes only for high risk, training of focus for anesthesiologists. Yes, this is happening slowly but surely. Yes. So we've not really gotten down to that, but we are in the process of doing it. So finally, your report includes all this. Okay. And present it. You look good. It really looks like you have done some work in order to improve quality and definitely impacts patient outcomes, right? Having said quality tools, audits, how about the anesthesiologists in perioperative medicine? Okay. How can we impact care preoperatively? PAC clinics, big place. Now, PAC clinics are gaining more and more importance because we're not only doing PACs, they're more like pre-optimization clinics. Where all can you work? Anemias. Okay. Huge role to play in blood management. If you're working on the anemia, you're definitely saving on blood transfusions. Perioperative cardiovascular evaluation, definitely. Okay. Can you do some work on POCD? This is something I picked up from the net and could be an interesting kind of a discussion as well. Post-operative cognitive dysfunction. So anemia clinics, definitely the use of preoperative erythropoietin, maybe iron supplementations 2 to 3 weeks prior. Okay, definitely can impact and decrease the use of packed RBCs that you may need to give to your patients, right? And that's huge. Good outcomes as well if you can save giving blood transfusion. This is an excellent resource. I would definitely advise all of us to go through the AHA guideline on perioperative cardiovascular evaluation for patients. I think most of us must have gone through this for non-cardiac surgery. Good resource for your own standards, to create your own standards. Yes. Okay. Delayed neurocognitive recovery. This is something I kind of chanced upon here. We know a lot, general anesthesia has a lot to do with post-operative cognitive dysfunction, right? And for this, I just went through the quality anesthesia journal, and well, in anesthesiology, they say, if you can have this sort of media questionnaire kind of a thing, which includes memory, episode, drugs, items, and aids. So you ask these questions. Have you ever had a memory problem or a thinking problem? Have you ever had an episode of confusion? Okay. And do you take drugs like, Aricept, Lorazepam, all these? So if the answers to 1, 2, or 3 are, more than 2 questions have a yes, then definitely things like the items, like personal items, like photos, favorite music, keeping the CD with the patient, or some visual aids definitely help. aids like glasses, hearing aids, to keep them on and reorient yourself before, during surgery and after. That also helps. So can this be one of those little studies that you can do? Simple things. These are going to be your standards, and well, how can we improve on the POCD aspect? So that's one aspect we can work on. Simulation improve patient safety. I think all of us definitely agree with this. Works on technical. We can do. It impacts technical, non-technical skills. It definitely improves system probing, right? And the NABH also has a standard saying that there has to be an ongoing program for professional training and development of staff, right? Why are we using simulation? Because basically, all of us are training adults, okay? And that is andragogy. So it refers to methods and approaches used in adult education, and it is actually directed towards self-actualization, meaning in simulation, you're actually creating a scenario, you are giving a safe platform for people to actually, make errors, discuss it, right? Simple things like, how can I do a kappa? Can you just recreate that scenario? Maybe we look at how we can think of solutions in that very nice thing that we do after a simulation exercise, that is debrief. So in our institution, that's what we've done. If an incident is reported, okay, it is reported to the departmental coordinator. It is analyzed, okay, and we're coming up with certain training needs of a learner, okay. On this, let's say, supposing I have a massive PPH, okay, and I feel that things didn't really go as per my plan. We didn't have some great outcomes. So I'm going to report this, and I'm going to come up with a simulation scenario. Yes, I'm going to rethink that event. I'm going to come up with a simulation scenario. Okay, they're going to be, is there a skill deficiency? From my team, I need to know, is there a skill deficiency in the doctors treating that particular case? Was there a knowledge deficiency? Is there an attitude deficiency? Okay. Pre-briefing of those trainers with the simulation department has to happen. Designing a program, coming up with those learning objectives on the basis of everything. Again, very important. Okay. Then a simulation scenario is run. After this, there is going to be a debrief, and of course, the feedback definitely tells me something. Okay, so it's kind of difficult to get feedback immediately, but really we're trying to do a lot of work as to how we can really get objective feedback after simulation exercises have been done. In our organization, we have quality improvement projects in simulation. We developed 2 simulation courses, small ones on our by ourselves, which is simulation in maternal emergencies and also simulation in post-operative care of the surgical patients, right? And well, it's a little difficult, it's a little difficult to ask. Well, I can always take a survey asking the consultants, do you think, outcomes have improved? But this is, I completely agree, quite difficult in terms of, how we can look at improvement or how there is objective improvement. There can be various things. There can be focus group interviews. There can be post-training feedbacks. There can be post-tests. But is it impacting outcomes? Yes, we're trying to look at things. If I come up with something, definitely a cause of discussion next time, maybe. So incident reporting system, we have an excellent incident reporting system in our organization. And as you can see, again, the 80-20 principle, there were handover errors, patient identification errors, communication errors. Maximum errors have been here during handovers. And that's worldwide, by the way, right? So that's how normally we have, an excellent incident reporting and a very frank and I must say, a very transparent one, followed very well by the nurses, definitely, and a lot of our staff as well. Okay? So I'm just going to end with one thing. I can't really teach anybody anything. It's very difficult. Only I just hope that this little exercise of the presentation, if I've really exceeded my time, I'm really very sorry. But if it's just gotten you to think, that is extremely important. So irrespective, thank you for all your time, and keep calm and definitely think quality improvement. And I would love to hear from you. That's my email ID. If you have any ideas and anything there, I can be of help for any solutions. I'd be more than happy. Thank you so much. Thank you, Shalini ma'am. Thank you, Sarita ma'am. Thank you, Kalyani and Shilpa for this opportunity. I'm sorry if I exceeded my time more than that. Over to you, Kalyani, Shalini ma'am, and Sarita. Thank you so much.
Yeah. Is there any question, Dr. Kalyani, from the audience?
No, no, ma'am, no.
Okay, fine. Thank you, madam. Thank you for your wonderful talk. You have nicely explained about the different domains of quality with example. What are the quality improvement tools that we can use to improve our anesthesia practice? Nicely emphasize on personal performance check. That is very important. Everyone must take some effort to check our self performance, how it is, and what we can do, what we can add with recent knowledge. And I need to get acquainted with the new tools, new technology, AI that we need to practice in our anesthesia to improve our quality.
Absolutely.
And you have given importance for the clinical audit. Actually, that is very most important part of this. And what action, corrective and preventive action we have taken on that. And definitely the role of simulation to improve the quality of patient care. Thank you very much for your.
Ma'am, if I may just interrupt, there is one question, Sheetal Dikshit ma'am,
Okay.
from Dr. Pathak.
Yes.
Most of the hospitals, they have small labs attached which are run by technicians without any pathologist. So can we expect the authorities to do something so that we get reliable reports from these labs?
So very interesting question, Dr. Mohan Pathak. Thing is, yes, small labs, but again, what is are they accredited, or, whether they are running those checks, validation checks, and their verification checks. This is extremely important. The authorities, yes, I mean, if to date, unfortunately, accreditation is still voluntary. ऐच्छिक आहे अजूनही. तुम्ही जर हे करायचं असेल तर ऐच्छिकच आहे. त्याला तुम्ही कंपल्सरी करू शकत नाहीये. But yes, I completely agree. It is really something that the authorities should be doing something about, because we've had really dangerous results sometimes from labs, and it can be quite alarming. So yes, I wish I had a better answer for that. I think that's where accreditation and standardization helps. Even an ISO standardization, something, wherein you're doing a verification, a validation, all you have all the tools. There is a central validation that you can do. You can do a peer review. All these things are there, but unfortunately, it cannot really be made compulsory. I wish it is. I hope that answers your question. Sorry.
Yeah. Okay. Should we go for third lecture?
Yes, ma'am. Yeah.
Yeah.
No
Yeah.
additional questions. Yeah.
No questions. Okay.
Yeah.
Thank you, madam. Thank you very much. Now we will move on to our third lecture. Third speaker is Dr. Shilpa Acharya. She is Professor of Anesthesia, PG Guide, and Lead Quality and Accreditation Coordinator at Bharti Hospital and Research Center, Pune. She has more than 15 years experience of anesthesia. She has done MBA in Hospital and Health System Management from BITS Pilani Institute in 2030. She has presented many papers, posters in different national and state conferences. She had published many articles, research articles in national as well as international journals. Apart from that, she is a very good dancer, as well as she writes poems in Marathi as well as English, and it has been published in many magazines, journals, and poetry books. So we have such a multi-talented speaker over here to talk on serious adverse events in anesthesia. Welcome, Dr. Shilpa.
Yeah. Thank you so much, ma'am, for this, introduction. And it is a privilege for me to be here today And at the beginning, I would like to thank SAP and Society of Anesthesiology Maharashtra State for making this wonderful platform of webinar available, and Dr. Swami Madam, Sardesai Madam, and Dr. Kalyani. So thank you. And the topic for me is, though it is very serious, I hope that I'll make it more interesting. So is my screen seen, Kalyani?
Yes,
Yeah.
yes, it is seen. Yeah.
Okay. So, friends, last 200 years of practice of anesthesia, we have definitely come a long way. And from something which is seen here on the screen to something, you know, like this, where we are actually giving anesthesia in these modular OTs, where all digitalized anesthesia machines and the state of art OTs with workstations in situ. But still, can we say that we have, we are giving a safe anesthesia care to our patients? So there are some errors, there are some events that occur, and such events, become a very stressful situations for all of us. And definitely it becomes a very life-changing lesson for all of us. So for next 20-25 minutes, I'll be talking about the serious adverse events in anesthesia. I welcome everybody. These are my learning objectives, and at the end of the session, I would like to emphasize on what is the future of serious adverse event reporting in India, and I would like to give 10 recommendations to prevent the serious adverse events. So let's start, from the definition of the event. It is been given, you can Google it, and it is something that is unexpected occurrence. And WHO also defines it as an incident that is unforeseen circumstance. It further classifies incident as uncompleted errors, that is near miss errors, incidents with no harm to the patient, that error has occurred, but it has reached the patient, but there is no harm, and incidents with harm. Now, incidents with harm are also known as adverse events, and they are further classified as mild, moderate, and severe. So let's dig deeper into the terminology of serious adverse events. Now, there are many definitions that are available, and it is something unexpected occurrence which actually, involves death or serious physical or psychological injury to the patient. Now, critical incident is another terminology which is also used, interchangeably with serious adverse event, and it also means that there is serious patient harm. Now, there are many definitions there are which have been given by different countries or different societies. Now, if you study all these definitions, in many definitions, there is a component of the patient outcome component has been given. Like, for example, the definition given by this Czech Republic, that there is a patient's physical, mental, and socio-economical harm. But the causation component, why the event has occurred, has not been given. Now, another definition, if we see that Royal College of Anesthesiologists, that it could have been prevented by a change of process. And this definitely means that this error was a preventable error. But definitely any error occurs in the anesthesiologist's life. There are two factors which will determine the outcome, that is the speed of the onset and the potential severity of the error. So what I just now said, this British Journal of Anesthesia, actually a wonderful article that has been published in 2022, which mentions that there are three components of any adverse event. One is a causation component, one is outcome component, and one is a preventability component. Now, causation component will give you, why the error has occurred. The outcome component will tell you the severity of the incident, and the preventability component will give you, how much is that error was preventable. And I'll come later to the preventability scale of the event. Now, another terminology which we are, very frequently, we hear this term as a sentinel. Now, what is it? Is a French word actually, which means something that guards, and it is a relatively infrequent, unexpected, and incident which is related to system or process deficiency. Now, let's see what NABH fifth program of implementation has to say about it. It says, particularly that the something which was not present in the patient when the time, when the services were sought, and it is something because the patient is admitted in the healthcare patient has received. So it definitely mentions that there was some error component in this. Now, Joint Commission says that it is a patient safety event which is leading to permanent harm or a severe temporary harm. Similarly, if you see the definition of National Quality Forum, which is a GCI affiliate, it says the word, this is the first time the word preventable is come in this definition, that any event which is preventable, serious and unambiguous, which is called as a serious adverse or sentinel event for that matter. And it is also known as a never event, because something which you would like to happen never ever in your life. Okay. Of course, all never events are not serious adverse events, but all serious adverse events are never events. Now, the last line that mentions the maximum errors or sentinel events that could occur in the healthcare. And if you see, actually, all of these are possible in our perioperative patients. So we are definitely working in a volatile field of anesthesia, and we should be aware of what serious adverse events could be occurring. So examples, let's see what are the examples of serious adverse events. The main adverse events, of course, we all know that it is respiratory. So there is hypoxia, difficult airway, desaturation, then followed by medication error. Mind you, 5% medication errors are found in the literature, that there are drug events in the anesthesiology. Then later on, there is cardiovascular and followed by nerve injuries. Okay. And this is a percentage which I got from one of the papers, that this is a percentage errors or, of different errors that occur. Now, let's see what are really serious adverse event preventable or not. Now, this is a draft guidelines WHO has published in 2004, that it definitely mentions that all adverse events are not always caused by error. Okay. For example, adverse drug reaction. Now, what is adverse drug reaction? It is not a medication error. It is something which is a side effect of the drug, and that is called as adverse drug reaction. It is not a medication error. That means all adverse events are not always caused by error, but many are caused by error, either error of commission or omission, and it definitely reflects there is something, there are gaps in your healthcare. Now, as I was talking about the grades or the preventability of error, now this paper, which was published in 2015, mentions, what are the grades? How will you, grade the error in terms of preventability of the error? Okay, now there are three, grades that have been mentioned, that 1 to 3 for avoidable, 4 to 6 for possibly avoidable, and 7 to 9 for probably avoidable, unavoidable. So from 1 to 3, if you consider, suppose, for example, if you give injection paracetamol to a patient who is allergic to paracetamol and he gets anaphylactic reaction. So this particular error is definitely avoidable error. Another error, suppose a patient with low ejection fraction, say for example 40% ejection fraction, and induce this patient with propofol, and there is tachycardia, hypotension, patient goes into failure. It is a possibly avoidable, because there are some patient factors also which are actually coming into play. And some errors are just because of the patient's, for example, a patient who is getting a pulmonary embolism, and landing into a serious adversity at the end of, say, fracture femur, then it could be a possibly avoidable error. Okay, so this scale has been mentioned in the literature, and we should be introspect ourselves, that whenever there is an error, you know whether it could have been prevented or not. Now let's see what is the problem statement. Now we all know that the serious adverse events do occur in today's day also, and the incidence is 9 to 10 per thousand anesthetics, and about 800 sentinel events come to JCI, though it is not mandatory to report. So this is a problem statement. And again, World Health Organization also mentioned that 20 to 40% of the healthcare expenditure is on the poor quality. Okay, there are adverse events still occurring in today's practice of anesthesia, and 40 million surgical procedures, if they are performed in just in the US, the 2 million medication errors are occurring. And you all agree with me that it is an iceberg phenomenon, that only very few are actually getting reported, but still they are occurring in practice. And that, I would like to mention that we always relate, a cost with a good quality, but you should remember that this is a something that you should think that the poor quality has extra cost, not the good quality. Now let's see why adverse event. What will happen if you don't report adverse events? What happens? So this is a latest paper, World Federation of Society of Anesthesiologists update 2024, that it says that critical incident reporting should be done, and it is a mechanism of gathering information that allows the identification of different contributing factors or different factors, why it had led to a serious adverse event, and it leads to quality improvement, as Shital madam has already emphasized on it. Then there is a risk reduction measure which we can get further on the practice, and it can help us improve the standard of anesthesia care. And the very important is it decreases clinicians' fear of the litigation, because there are medical legal repercussions that is associated with any adverse events in the healthcare. So what will you do, when a serious adverse event occurs? So you have to report, please, you have to encourage your colleagues, yourself, your department people, that you report your serious adverse event, and they should feel free to report the event. That is a very important, as has already been mentioned, that you should have a safety culture. At our institute also, uh, we actually encourage people, at the minutest of the year an error or near misses, we keep encouraging people, and especially nursing staff, to report the error, so that we can understand what are our deficiencies in our system, and processes. So you have to report the adverse event in 24 hours. Then you have to write the information regarding the details of the event, such as patient demographics, who was the anesthesia provider, what was the procedure, comorbidities, the description of the event. Then you have to investigate the event, whether you require some investigations, and then assess the contributing factors. I'll come to root cause analysis later, and you can actually see some weaknesses in your system after you investigate your serious adverse events. Okay, and of course you have to maintain the confidentiality, because there are some, as I said, legal factors. So let's see what is a root cause analysis. Once you report an incident, there should be a root cause analysis which is followed. Okay, you have to actually identify what are the causal factors. Now, if in anesthesia care, it is a very complex procedure, the perioperative care, in any patient. So in the anesthesia practice as such, there are multiple factors that are involved. There are factors related to patient, related to anesthesia technique, related to surgery, the post-operative care. Then there are nurses, there are instruments, there are equipment. So there are multiple stakeholders that are involved in anesthesia care or a perioperative care. So whenever there are multiple factors, you should always go for what is Dr. Sheetal has already mentioned as a fishbone diagram, and it will definitely lead you to the actual deficiencies what had led to the incident. Another is Pareto chart. So if you think that there is a single most important factor which had led, suppose you think that your training is not right. So just doing your training, you will overcome all your 80% of the deficiencies in your system. And majority of the process delay, if there is a process delay, suppose there is a delay in the PAC, which is patient getting fit, for example. So you have to ask the 5 whys of the root cause analysis. I won't go into details as it already been discussed. So these are different root cause analysis methods, and you can take help of a quality person in this, definitely. And this is something which very interesting that I found, and you can develop your own algorithm. See the algorithm shown in the picture. There is algorithm for respiratory failure, cardiac arrest, and hypovolemia. So what was the cause of respiratory failure? The different limbs they have been given: central cause, airway cause, muscle, lung, and you can develop your own algorithm and actually coming to the causal factor which has already led to the serious adverse event. Now, after root cause analysis, the next step is the correction and the corrective action. Now, friends, there is one small difference between what is correction and corrective action. Now, for example, if I'm working in the operating room and I trip over a cable which is on the floor, and I get head injury, or something on my head, right? So, what is your correction? Correction is to cater to the person who has had a fall. See whether he has had a head injury. If there is a wound or CLW, you cater to the wound, do a suturing if it is required, and that will be your correction. Okay, and what will be your corrective action? Corrective action will be, you will be removing the cable from the ground, because this is a trip hazard, right? So similarly, in the serious adverse event, the correction is first is to stabilize the patient. Okay, look after the patient, do immediate investigation, comprehensive systematic review, and you have to mention the timeline, because that if you mention the timeline, it gives you a certain, everybody a certain responsibility that you have to complete it within the given timeline. Then, as was mentioned by Verma sir, that barcode system for medication administration, it is a very important thing, and we can actually do, because in the technological advances we can actually go for the barcode for medication administration. And the next is you have to disclose the event to patient and family. Now, in India, what is the scenario? Now, the disclosure of the serious adverse event is called as open disclosure. Now, which is something which I would like to discuss the end of my presentation. That it is still something not common in India, but it is being done abroad routinely, especially in Australia. The next step is to provide support to the family, because definitely there is a serious adverse event, there is a adverse patient outcome, so you should support the family and the relatives. Yeah. And the next is the staff who is involved, because the patient who is involved in the adverse event is called as the first victim, and the staff which is involved is called as second victim. Many a times that second victim is under stress because there are medico legal problems that are involved, and therefore that stress should be removed and organization should provide, and it's a very important step that you should take. And then you should of course notify the hospital leader about the serious adverse event. Now let's come to the preventive action. Now let's continue with the example of trip or on a cable, which I've given. That what is the preventive action of the this incident is that I will go to every operating room and remove the cable from every see that there is any trip hazard in any other operation theaters. So that would be my preventive action. So in case of serious adverse events, you have to identify the system factors and work on all those factors, right? Then there are critical incident reporting protocols that you should form, practice proper documentation, and continuing professional development activities are very important. And you know last but not the least, you have to blame the process and not the person, okay? Because usually the human errors, the individual errors are there, but many a times the individual errors are around the training, and the training in any organization, it becomes a process factor and not the individual factor per se. Now, all this, everybody knows this, but still there is less reporting. No, why there is? Because again, as I said, there are process factors. There is fear of reputation. Why I would like to discuss about the something which has happened in my OT. So there is criticism and medical legal repercussions that will happen. Now, is it mandatory in India? Let's see. Now, Joint Commission as well as NABH, they encourage, but it is not obligated, mind you. So that is why the reporting in of the serious adverse events is less. Now, this paper of published in British Journal of Anesthesia, mentions that how you can report the serious adverse events. Now, there are three techniques. First is the anesthesia information management system. Now, if you're having electronic health records, then they will be automatically, captured by electronic health records. Suppose there is an event of hypoxia, event of bradycardia or cardiac arrest. So these will be captured by your MIS. But if you don't have, you can specially have an anesthesia information management system software. Second is you can self-report. Okay, like most of the organization, in our organization, we encourage the self-reporting of the adverse events and sentinel events. And the third is the capturing the incidents afterwards from the MRD by international classification of the disease. Okay. Now, a word about the ICD coding, which is done of the adverse events. Now, if you see, the adverse events are classified by double digits, and the ICD-10 coding is followed. Of course, ICD-11 will also come, but something adverse event which is related to surgical procedures, comes into Y60 and Y61. So suppose if you retrospectively see your files, in the MRD, then you will understand that the coding which has been given to that particular, and that way you can actually, um, make the, get the data of the adverse events. Now, what is happening globally of, uh, capturing of the data? Now, Australian Patient Safety Foundation, they are having their anesthesia management system. Even in USA, there is anesthesia management system. And if you see in this figure, there is a matrix, 4 by 4 matrix that has been displayed. So the x-axis and the y-axis. Now there is severity on the x-axis, and on the y there is a probability. Now something which is likely to occur will be most probable, and something which could be very catastrophic is the most catastrophic, and which will get a 16 points. Okay, something like a Lassa drug error. Suppose midazolam and scoline vials are kept side by side, and nursing staff gives 1 mg scoline instead of midazolam, and the frequency of such incident is likely to happen very high, and the event is likely to be catastrophic. That particular incident will get 16 points. So this way we can actually do a proactively risk assessment and the severity assessment of any particular incident. In American Society of Anesthesiologists, they also have a national patient safety agency, and in the Great Britain also, an Australian incident reporting monitoring system is there, and there are routinely audits that are conducted for the serious adverse events. Now let's see what is happening in India. Now, when I search the literature in India, now there are guidelines given by Indian Society of Anesthesiologists, okay, and there are portals, online portals given by Government of India, Ministry of Health and Family Welfare. This is the portal that is available. There are guidelines regarding the serious adverse event, the critical clinical trial, but serious adverse event in the healthcare and anesthesiologies have not been mentioned anywhere. Okay, so there is a lot of scope for analysis, for literature, for research in the serious adverse event section. Now, this is a paper which was published in 2009 in Indian Journal of Anesthesia by Dr. Sunanda Gupta and team, and it is a very, very beautiful paper that they have mentioned that more than 14,000 anesthetic they had studied, in which more than 100 critical incident the authors have mentioned. This is in 2009, and the authors are brave enough to mention that human error was the most common responsible factor regarding the anesthesia related critical incidents, and they said that you should emphasize on the protocols and strategies, checklist and awareness, okay, about the serious adverse events. After this 2009, I could not actually find any literature in India about the serious adverse event. Now let's see what is actually happening. What is our government of India doing regarding? Yes, there is something that they are doing, and you just read this National Patient Safety Implementation Framework. The time limit is 2018 to 2025, and let's see what it gives you. The strategic objectives that are mentioned here are 6, and see the second objective: to assess the nature and scale of adverse events in healthcare and establish a system of reporting and learning. Okay, so this is a very important strategic objective which was never there otherwise, and it is there in the pipeline. Now, if you dig deeper, read it, let's see what 2.2.1 this thing says, that you have to develop the patient safety incident surveillance system and system of reporting and learning from all the adverse events and near misses at national, subnational and healthcare facility levels. Okay, so this is something which is a very welcome move from the government of India. And if you see, there is a special clause on mandatory reporting of all the adverse events and near misses is incorporated. So time, it will be done under Public Health Act. Now, Public Health Act, when it will be implemented in India, I think it has started in from Kerala. So when it will be there, all over India, we will have it will be a mandatory reporting of the serious adverse events in the healthcare. So now we are having a pharmacovigilance, we are having vigilance, we are having hemovigilance. Similarly, there will be a mandatory reporting of the adverse events in India as well. Now, in the Public Health Act, which is a proposed act, What does it say? It will make provision for mandatory reporting of adverse event by all healthcare facilities, and the adequate legal provisions will also be provided. And it is a very welcome move, and something which is happening abroad, in Western countries or in Australia for that matter. They are actually providing a legal support to the healthcare workers as well. And there are guidelines for errors, adverse events. So it is a total, public health act. It will definitely be an helpful document, and about the serious adverse events. Now let's, I've come to the end of my talk, that I'll be, completing with my recommendations to avoid the serious adverse event in future. Now, it has been mentioned that more than 2,000 incident, have shown, a theoretical analysis of more than 1,000 incident, and all the studies have shown that if pulse oximetry and capnography was used in a patient, these events would have been detected earlier, 65% even before the potential permanent damage. Okay, that means, this guard is all with his armor, and similarly, the anesthesiologist with his monitors. So the recommendation one is, you should put on the monitors. Even if the patient is ASA1, you will feel that it will never occur. Please put on the monitors. Now what is second recommendation is, anesthesiologist should fully understood the pharmacology of the medications. Please, rehearse in your mind that whatever drug you're giving, there is no contraindication to the patient. The drug history should be, don't rely on your juniors, okay, or other team member has, maybe asked about or allergic history. Just do it yourself. Label it fully. I remember one incident which had occurred in my OT, that JR2 was holding the mask, JR3 was giving the drugs, and there were two syringes, 4 cc. One was GME, that is glycomidaz and MSET, and another was vecuronium. I was standing at the right side of the patient, and I told my JR3, start pre-medication after checking, all surgical safety checklist. So I, from the corner of my eye, I could see the syringe of something written like V on the syringe, and by that time I could actually recognize. I told her that, what is, just show me the label of the syringe, and it was written vecuronium. And by the time I could actually mentioned to her, already 2 cc of vecuronium was given. And then again, we realized in time, we gave pre-medication, I held the mask, we intubated the patient, it was uneventful. But medication errors, and we all tell our ward nurses, your ICU nurses, to go for the 6 rights of medication safety. But as an anesthesiologist, we are the one who are writing prescription. We are the one who are loading the drugs. We are the ones who are administrating the drugs. We are the one where we are monitoring after giving the medication and documenting. So everything has been done by anesthesiologist. And mind you, you must know the 6 rights of medication safety thoroughly. Okay, now this is a classification of medication error, which has been given by the National Coordinating Council. Now, coming to the third recommendation is that, as you see in the picture, many departments, they work in the silos. There is some communication within the department, but whenever you talk about a surgical patient, there are multiple stakeholders that I have already mentioned. That there is a department of surgery, department of anesthesia, then there is nursing, and so on and so forth. So there is no communication between the two departments. And this is something called as a silo mentality, and you should break the silo, because 70% of the serious adverse events are because of the communication error. And therefore my third recommendation is, the communication is the key. Communicate with your surgeon, communicate with your nursing staff, communicate with your patient. Involve your patient. Many times patient doesn't know the name of the anesthetist. They know who is the surgeon, but anesthetist name they don't know. So please communicate with the relatives. Tell them that this could happen, I'm going to do this, these are the steps. So communication is the key. Next, this model of structure, process, and outcome, and it is a famous model given by Donab-Edian model. Okay, now these are the gaps which Dr. Sheetal has already mentioned, that these are the gaps in the system, which you can actually identify by brainstorming. So there could be gap in the structure, there could be gap in the processes, or in the outcome. So the different indicators or the quality indicators that have been given by NABH and JCI, and there are multiple indicators that you can actually implement in your practice. Okay, so you have to take small steps of quality improvement every day. The minute you understand that there is a gap, suppose you understand that the consent is not getting, you should add certain things in the consent. So please do take that step and improvise your care. So the next recommendation is, take quality improvement projects, go for clinical audits in anesthesia. Now, this is a typical Swiss cheese model. Now, there was an error, which had occurred in an institute, that when there was a patient admitted in the oncology, and the medication to the patient was wrong medication was given to the patient from oncology. Now, when the relatives were actually seeing that the patient is receiving some different medicine from the regular one, the patient relative actually noticed that the medication which is being given to my patient is something different, and then he pointed out that error to the nursing staff, and this actually proves that the process errors has occurred at multiple steps. The medication was prescribed by the pharmacist, from the pharmacy, which was wrong. The medication which was the relatives also could not identify that is when it was prescribed. Then the medication was brought, clinical pharmacists actually prepared the drug, but they could not identify. The nursing staffs administered the drug, but they also could not identify, and it actually led to the error. So something like this keeps on happening day to day life, that when all the holes match, the accident occurs. So all the process errors, you have to, your one adverse event will actually tell you where are the holes in your processes or your system. The next is the WHO surgical safety checklist we all are aware of, and the intraoperative complication rate has definitely gone down because of the regular use of surgical safety checklist. Okay, so my next recommendation is you have to make friendship with the checklist. There is a preoperative checklist, there is postoperative checklist, WHO surgical checklist. Everybody knows who is the surgeon, the patient, but don't feel shy. Verbalize it in the OT. Tell your nursing staff, see for mop count, check your anesthesia machine, tell your surgeon, drug patient is allergic to that particular drug, there is a more than 500 blood loss is expected. Please verbalize it. It definitely makes a very team approach when you actually verbalize the surgical safety checklist in the OT, and that is why you should make friendship with your checklist. Okay, and the next recommendation is the documentation. Okay, because sorry, the equipments. Now the biomedical engineers are there to help you in the OT. Okay, and there are multiple equipments, like from laryngoscope through your anesthesia workstation. So please see that your machines have been checked every day, they have been calibrated, your oxygen sensor is working, your suction is working, your laryngoscope battery is changed. So please check your equipments regularly. Now, ASA place classification we all are aware of. We are routinely using. It is a very gold standard, in anesthesia practice. But it also has its own limitation. Now, if when I actually searched in the literature, there are more than 30 risk stratification tools in the perioperative patients. Okay, and this particular paper, which was published in 2030, actually gives you the stratification tools for predicting morbidity and mortality in adult patients undergoing major surgery. So you can have a different risk assessment tools for perioperative patients. One of the other tool that is routinely used is surgical Apgar or modified surgical Apgar score. So please do risk stratification. Now, why risk stratification is important? Because that will tell you to gather additional resources if you want. If you want another anesthesiologist, do not shy away from taking another helping hand. So that is a very important thing, and that's why you should do a risk stratification in all your patients. Okay, now the next recommendation is the documents. Okay, you all know that if it is not written on the paper, that means it is not done. So the next recommendation is, please go for proper medical documentation. If there is an adverse event, please document it chronologically, timely, minute to minute documentation. counseling of the patient, please write it on paper. Counseling notes. You can have a video conferences for counseling. So at our institute, we also have a facility, in certain areas that we do video counseling of the patients and record it, so that that is a important evidence that we have counseled our patient. So remember to do a proper documentation. The next is there are individual errors. We cannot uh, deny that there are individual errors. Now some of the individual errors are inexperience, insufficient attention, somebody who is very worked up because of emergencies. There are certain wrong decisions. Again, decision making in anesthesia is another topic altogether. So there are individual factors which actually are responsible for leading to a serious adverse events, and therefore training of your staff, capacity building of your staff is very important. And you can take help of the simulation training in particular, because it is a controlled environment in which you can actually enact all the serious adverse events. Like last week we had a mock drill and the simulation this thing, simulation lab of our institute, of a fire in the operating room, where the patient is, critical patient is getting operated and there is a fire, electrical fire. So such activities actually are a very learning experiences or learning, program for all of us. Now the National Patient Safety Agency, it has created the incident reporting software, and there is open and fair culture in the hospital, and that only will encourage the uh, actual reporting of the incident. And therefore my last recommendation, that there should be a structured incident reporting system, and you can have a clinical governance meeting in which the incident can be discussed in a closed door meeting, and so that there are no repercussions, because some matters in this, you cannot disclose all the matters to everybody. So you can have that clinical governance for discussing serious adverse events. Now, last few words about the open disclosure. Now, this is something which is practiced abroad, especially in Australia. My senior colleague, I actually contacted them the other day, that they actually told me that one who is in Denmark and one who is is practicing in Australia, they actually told that whenever there is serious adverse event in the operating room, they go to the patient's relatives, they discuss and openly disclose all the event that has occurred in the OT. Okay, factual explanation. They says that we are sorry. Okay, this is the thing that are routinely done in Australia, right? And in case of any error from the organization, the matter goes for the legal cell and the coroner if there are any legal this thing involvement that occurs. And India, this is, this present scenario, this open disclosure is really, we are not on the horizon, but this is being done abroad routinely. Now there are legal perspective, and these are different laws, like Public Health Act in India that would come, but these are different laws of, apology or expression of regret, which are there in, foreign countries. And the legal, of course, legal aspects of the serious adverse event also you cannot ignore, because the maximum close claim analysis, if you study the maximum claims for anesthesia practices for medication dosage errors, awareness, hypoxia, and difficult airway. Okay, so these are the maximum errors occurring in anesthesia and getting into litigation. Now, this is a MIMS, which is a minimum information model of patient safety incident reporting, which is given by WHO. You just Google it. I just wanted, to mention it. And so at the end, I would like to mention that all the good doctors and good nurses, we do make mistake, but critical incidents are rarely caused by one person alone. Okay, so you have to, as was Aldriel mentioned, that you have to involve the family, the patient. And now the national patient safety, your guidelines, that mentions that engage your relatives and engage your patient in the patient safety. So as anesthesiologist is an important stakeholder, as nursing staff, as surgeon, the patient himself and the relatives are important stakeholder in the patient safety. So involve the patients And we are also in our hospital, we are starting this patient advisory council, so that the patient gives us some idea, some insights that we can work upon, from the patient perspective. Okay, thank you so much for the patient listening. Always a serious adverse event, they are the hardest time, but either you come out triumph or you become experienced. So thank you so much. Thank you, ma'am. Yeah, thank you, everyone.
Is there any question from the audience?
No, ma'am, no.
Okay. Okay, thank you, Dr. Shilpa, for your wonderful talk on perioperative adverse events. You have nicely elaborated various grades of adverse events, grades of preventability, how we should go for root cause analysis, what corrective and correction and corrective measures and even preventive measures we need to take for all these adverse events. And definitely you have given nice recommendation to overcome all these adverse events, and I'm sure everybody will follow all these recommendations and we will overcome. Yes, and lastly, as you said, the reporting of the adverse events is very, very essential, so that next time we can take a preventive, corrective and all measures to avoid the repetition of the mistakes. So thank you once again. So at the end, I would like to conclude the overall seminar. As our speakers mentioned that perioperative complications are very common, either because of poor care of patient, lack of knowledge, poor skill, lack of assessment of our own skills. Errors are definitely contributing factors. The safety culture in the perioperative setting addresses critical components important to healthcare, including patient safety, staff support, and the identification of system issues. These concepts are important to healthcare in general and critical in the high-risk peri-op environment. Hence, an approach that emphasizes understanding, integration, engagement, and accountability for safety by each team member for every patient, every time, every day need to be implemented. Thank you all speakers. So at the end, I would like to thank, on behalf of Society of Anesthesiologists Pune, I am very thankful to all the dignitaries of national as well as state ISA body for providing this virtual platform to conduct this academic activity, as well as for your continuous support and encouragement to conduct such activities in future also. I'm also thankful to all faculties, speakers for enlightening us on different aspects of quality in anesthesia. And I'm sure everyone will get benefited from this seminar. Thank you all delegates for your presence and making this activity more successful. Thank you, Jebeka Tech, for all your technical support you have given for this virtual this webinar. So once again, thank you. Thank you, everyone.
Thank you.
Long live ISA.
Thank you.
Thank you.
Thank you.
Thank you, ma'am. Thank you. Thank you very much. Bye-bye.
Thank you so much, everyone. Yeah.
Thank you. Bye.
Yeah. Bye.
Bye. Thanks.
Bye. Bye, ma'am. Bye.
Bye, ma'am.
मॅडम लेक्चर खूप
Bye.
छान झालं सगळ्यांचंच खूपच
Yes,
छान.
yes, everyone.
Very
It
nice.
was
It was
very
Very
informative.
informative and different
Yeah.
inputs.
Actually,
you.
I think we should conduct it again for a large audience also. It's a very
Actually,
important topic.
yeah.
है ना?
Yes.
Actually, I was suggesting, I mean, I spoke to Shilpa also that we can think of including it, some part of it in PROACT as well, as a, quality session,
Yeah,
like
yeah.
a panel discussion or something.
Yeah, panel discussion is a good idea.
Yes,
We
yeah.
can call all these panelists.
Yeah,
these
yeah.
speakers
It's
at the
Yeah,
same
that's
time.
what, yeah.
Thank you, Sardesai madam, for I can making yourself available last moment. That was
Oh,
Actually,
yeah.
She's our safety net always.
Oh.
Plan B, plan
Actually.
B.
कल्याणीने ऑर्डर
Plan B.
केल्यावर मी नाही कसं
Oh,
म्हणू?
madam,
Oh.
please. Please. There you go.
Thank you, ma'am. Thank you, Shalini ma'am.
Yeah.
Thank you,
Yeah,
Kalyan.
thank
Thank
you.
you so
Thank you,
much.
Sheetal madam. Yeah, yeah.
Then
Bye.
madam,
Bye,
thank
bye.
you.
Bye, bye.
As
Bye,
usual.
bye, bye.
Bye. Thank you.
Yeah.